This is an abstract that is submitted by a junior faculty member here, John Webster, who heads up our ALL approach at Johns Hopkins. And this comes about from kind of me prodding him to look at how we are doing with Philly positive ALL. Our impression was that we were doing pretty well, but it's always good to go back and look. And we looked at 81 patients who had been undergone allogeneic transplant. Our approach at Johns Hopkins for any patient with Philadelphia chromosome-positive acute lymphoblastic leukemia is we will usually try to have the patient undergo an allogeneic transplant. We almost always can get them in a good remission with initial therapy using a tyrosine kinase inhibitor and a little bit of chemotherapy. The question is, should everybody go to an allogeneic transplant? At Johns Hopkins, because our transplant-related mortality is so low, we tend to offer transplant to the large majority of patients. You've got to be pretty fleet of foot or quite old to avoid a bone marrow transplant here at Johns Hopkins with that disease. It certainly happens. But with that was still done without the benefit of randomization. And so we always like to question how we are doing. And we went back and looked at a number of features related to the transplant. One, which TKI should we use? Two, should we be using a myeloablative transplant versus a non-myeloablative preparative regimen? What about maintenance? And can we learn anything about pre-treatment? What we've been doing at Johns Hopkins is giving just a little bit of Vincristine and steroids, and this is modeled after work initially out of France with a group headed up by the first author Chalandon, and we often refer to this as the Chalandon regimen. But it's simply Vincristine, steroids, and a tyrosine kinase inhibitor. Patients have an extraordinarily high remission rate with that in the newly diagnosed setting. And we generally will then move them to allogeneic transplant and give them maintenance. And we follow BCR-ABL and for measurable residual disease along with multi-parameter flow cytometry. And our outcomes were really were very reassuring. And it looked like our best group were patients that were receiving this very low intensity chemotherapy with Dasatinib, which is a second generation tyrosine kinase inhibitor, would then go to a non-myeloablative conditioned transplant and then get Dasatinib maintenance. And we were looking at outcomes that frankly were approaching long-term survival of approaching 80%. So with that 75-80%, we felt, gee, we better at least report this. This seems far better than when I entered the field 20 or 30 years ago, where virtually everybody with this disease died. And I think all over the world, people are finding similar things. We're all coming at the problem slightly differently. Again, we have a transplant platform here that we apply to just about everybody. And so we can pat ourselves on the back and say, yes, it works as well as anything we've seen around the world. But I think the bigger picture is this particular disease subset. These patients are just doing, particularly in the last few years, extraordinarily well. And everybody is kind of saying, here's something here's a hill that we've conquered. We haven't totally conquered it, obviously, but we've come a long ways in the last 20 years for this disease.